Dr. Walpoth, you're one of the world's most experienced surgeons using and employing transit time flow in your practice. I believe now you're retired from surgery, right?
Correct.
But
yes.
but you used it. You were an early adopter. When did you start using transit time flow measurements? And relative to your career, how long had you practiced without it?
Yeah, well, I practiced half of my span as a cardiac surgeon without, and the second half with.
Okay.
And that was about 20 years ago we started, really at the very, very beginning of the company.
So the very earliest of flow meters you used.
Absolutely. I think we did the first cardiac cases in Europe.
Okay.
With transit time and with medicine, probably even the first in the world with medicine. There was one report out from a competitor who tried the same thing in the US.
Mm-hmm.
But I think we did the first in man with...
okay, so there you go. There's the history. So now that we've dated you, when you first started using it, we didn't really have that much confidence in the endpoints to tell you that a graft was functional or not. How did you use it, and how did your knowledge and understanding of the data change to the point where you really relied upon it as a tool?
Well, this is a whole process basically, and the first thing we did when I discussed that with Anne Grip and Jon Höhm at that time, was I said, well, this is great, it's absolutely great, but first I want to know if it works. And if we did a validation study first to see if it really does measure what we want to measure and how is the accuracy and the precision of the method, but it was excellent. And simultaneously we introduced it also in the clinic, and of course the surgeons were a bit reluctant at the beginning, because every surgeon said, we do a good job, we know when we do a bad job, we don't need this. This is a typical reaction, and it's only with time showing them that they can get some advantage of knowing, having a real objective measure to what they have done, that it could have really an importance on the work at the time of surgery, but also maybe in the future.
What does a surgeon need to see to go from being skeptical to being an advocate to the point where they won't do CABG surgery without it?
Well, I think what happens to every surgeon, and in one point or another in his career, is that he has a failed graft. And a failed graft, if he has now this measurement which clearly shows him that there is no flow, and he redoes it and he sees that there was a flap or a problem, and he can correct it, and just a few minutes after the correction he has a perfect flow. This is, I think, the
that's the epiphany.
Yeah,
the lights turn on at that point.
It's absolutely, that is really most of them. And then, of course, now in all these years, there have been so many studies on quality control, on assessment of flow, on the assessment of intraoperative compared to postoperative, and then also in the long range patency of these grafts. And this is now the science behind it, showing that there is really a value to do it.
From a clinical validation standpoint, do you think that there is now enough research and enough data out there to say this is a device that should be a standard of care?
Well, I really think with the last bit of research done by Teresa, with the introduction in the guidelines, I think we are quite confident, and I think everybody should be quite confident to have this as a tool to be used. But I'm afraid, because I know around me and also from you, that this is not the case in many clinics still, that it's not done at all or not done routinely, and I think...
So talking about routine use as opposed to at all, because we do have a lot of people that say, I only use this device
yes.
when I think I have a problem.
I know. But
so what's the, what do we say to somebody like that?
Well, I think it's also it's an approach. I'm not saying it's a good approach, but it's an approach. I mean, if everything goes well and they have always done it without, and they have a flow meter in their institute for the very difficult cases or the cases done maybe more off pump or with younger people, I think it's a good thing to train them to use it. But you cannot maybe convince or force an older surgeon who has always done it not to do it.
And it's not just older surgeons.
Yeah, they're also younger surgeons.
Yeah,
that's
right.
true. That's true. But I think if you have a big institute, which is a teaching hospital, I think it would be absolutely mandatory, in my view, for the chief to reinforce this practice to do it in all the cases. Mm-hmm. It gives stability, gives feedback to the younger surgeons also, and gives eventually even a quality assessment for the long term of what has been done. Yes.
Some surgeons might say, if they're using our device and they come up with a result that's maybe not optimal,
right?
Mean flow is questionable.
Right.
Certainly pulsatility index is going to be 7, 8, 10, 11. And they say to us, well, I expected that because I had a compromised outflow bed or I had a bad target. Is this acceptable? Or what do we do with that?
Yeah, well, these are the borderline cases, and you will always have borderline cases in your practice. It's a matter of confidence of the surgeon in maybe the possibility that this outflow bed, as you said, or this high PI and high resistance might change over time. And we have published a study in the Journal of Thoracic Cardiovascular Surgery on this, that in fact the EMA or Lima anastomosis and graft show lower flow, if you take it overall, has always been lower, despite the fact that the region of interest, which is the LAD region, has highest muscle mass. So there is a discrepancy, and this discrepancy is probably inherent to the mammary artery, and which will then, with time, remodel and increase the flow. This has been published, has been studied in about 30 patients, and in a very good journal, and it's not only us. Other people find also it's strange. Why do we have lower flows at the beginning?
So okay to accept something marginal
yes,
occasionally.
this can then also be part of the decision making for accepting something marginal.
Okay, that's good. So we can provide some comfort in our guidance to say
I think so.
It's okay to
I think it's
things
not,
change over
everything
time.
is not black and white
Dynamic.
in medicine. In medicine, it's an
not?
art.
Oh, okay.
No, it's an art.
Okay.
Right.
Dr. Walpoth, where do you see the future of quality control with cardiac surgery, particularly CABG surgery, going?
Well, I think the flow measurement should be integrated everywhere, in every center and in every CABG surgery done. Now, this is easy to do. There is no excuse not to do it, and I think will be sufficient in about probably 95% of the patient. 95% of the patient will do fine with these guidelines and with this flow measurement. Now there is this 5%, and there is a question: what shall we do? Of course, we can use the imaging modality, which will help. I'm speaking now of quality control of CABG. The imaging might help in other findings or defining aortic and finding your coronary. This is something else, but I'm speaking now purely in assessing the quality of your anastomosis. And this, in certain percentage, it might be helpful for the surgeon to have the tool immediately in the OR to look at his anastomosis, how it looks like, and to decide on this basis to redo it or not to redo it.
So you're saying that the technology is good enough, the problem is getting more people to adopt it universally or as a standard?
I think the technology is here, but especially the flow measurement technology, I think this is good enough, and it's reliable, reproducible, and there is not a problem. The imaging addition is anyhow more difficult, that is clear, because of the moving target. It's more difficult, but it's also more difficult because people have not used it so much. There are no real guidelines yet, and especially you use this imaging technology, you use it mostly on the difficult cases, which are anyhow difficult to make a decision.
Right.
Then you have this additional imaging, which probably will help you to make the right decision for the patient.
Do you have anything you'd like to any message you'd like to offer?
One of the messages.
Somebody who has been around for 30, 40 years in the practice.
The message is that, of course, I mean, it has been a fantastic 20 years of evolution with your company, with this technology and your company, and basically what is fantastic to see that we have been able with this to improve the quality of the work we give and the revascularization procedures we do for our patients. So basically there is a problem, there is some question how to get there. There is some research involved, a lot of research involved, and finally there is even a statement that there are guidelines with good evidence, and this is will serve definitely not only cardiac surgery but mainly the patient, and that is what we are here for.
Very good. Well, thank you for your time, Dr. Walpoth. I really appreciate it, as always.